Welcome everyone in today's East Delhi Gynae Forum meeting, which is on adnexal masses in women and the most common problems which we always face in this, perimenopausal as well as menopausal women, which comes to us in our OPD. And we always get confused how to handle such adnexal masses, and especially the most common ultrasound diagnosis of complex adnexal mass. Then we all get scared whether it's a malignant or it's a benign and how to approach it. So this CME is dedicated to approach to adnexal masses in women, and we have our first session, which is a talk which will be taken by Dr. Bindiya Gupta, and the next session will be basically a panel discussion, which will be moderated by me. So we are coming to the first session. I invite the chairpersons for the academic session, Dr. Ila Gupta, Dr. Raj Bokaria, and Dr. Jyoti Bhaskar, ma'am. Dr. Ila Gupta is a senior consultant in Max Hospital, Vaishali and Patparganj. She's a graduate and postgraduate from KGMC and is practicing in East Delhi for more than 30 years. Ma'am was a founder member and the past president of Delhi Gynae Forum East, and presently an advisor of East Delhi Gynae Forum, and she's been awarded with many prizes. Dr. Raj Bokaria, ma'am, is also senior consultant associated with Fortis Law Firm and Max Patparganj Hospital. Ma'am is area of interest is gynae endoscopy and urogynecology, and she was a founder member of DGES and organized many endoscopy workshops, and was past president of East Delhi Gynae Forum and presently advisor of Delhi Gynae Forum East. We have Dr. Jyoti Bhaskar, ma'am. Ma'am is a current president of East Delhi Gynae Forum. Ma'am is a principal consultant of gynae from associated with Apollo Cradle Hospital, Indrapuram, Delhi. And she is co-chairperson of AOGD Subcommittee on Quality Improvement 21-23 and Secretary of Delhi Chapter of Indian Menopause Society 21-23. And I request Dr. Jyoti Bhaskar, ma'am, to please invite our speaker, Dr. Bindiya Gupta.
So thank you so much, Dr. Meenakshi. And it is indeed my honor and pleasure to introduce and invite Dr. Bindiya Gupta. She's an associate professor in the Department of Obs and Gynae at UCMS and GTB Hospital. She's got her Commonwealth Scholarship in Gynae Oncology from UK. She's an IFCPC IARCP certified colposcopist and has contributed several national and international papers to journals and has authored books and has been an editor of 6 books. She has been an extremely dynamic person with a lot of leadership qualities. She's held important positions in AOGD, ISCCP, as well as AOGIN. And she has been awarded several awards. Both, she's, I think very early in her career, she has been awarded the FIGO paper, that's a FIGO Prize Paper Award in 2006, the Foxy Junior Korean Award in 2018, and she's been a runner-up for the Yuva Achiever Award in 2018. So Dr. Bindiya, over to you. We are already waiting to hear from you about the adnexal masses.
Thank you very much, ma'am, for the kind words and the kind introduction. And at the outset, it's my honor and privilege to be a part of this forum. Thank you, Sharda Jain, ma'am. Thank you, Jyoti, ma'am. And thank you, Dr. Meenakshi, for making me a part of this gathering. So I'll just start my presentation. Okay, sorry. I hope my screen is visible.
Yes, visible.
Yeah, all right. So today's topic is very interesting and a very close to heart topic. It's close to adnexal masses in women, which is the greatest dilemma which is being faced nowadays. So accurate characterization of adnexal masses is of paramount importance in order to decide the right treatment pathways and to achieve the right outcome. What we need is to preoperatively identify the masses which carry a high risk of pre-malignant and malignant disease, and thus tailor our management appropriately and achieve the right outcome. So we have 3 important methods in our armamentarium to characterize an adnexal mass. One is the clinical presentation, second is imaging, and third is tumor markers. So while we are evaluating a woman who comes to us for the first time in a history, always try to identify the high-risk groups which will carry a high risk of pre-malignancy or malignancy. And these are the women who are at extremes of age, be it a young premenarchal girl, a woman in a girl in an early adolescence, or a postmenopausal woman. Then women who are nulliparous, who have a history of infertility, endometriosis, again, these are at a high risk of carrying a borderline or a malignant mass. And as we all know, a family history is very important, especially of breast, ovarian, endometrial and colorectal cancers, because then here we have the hereditary ovarian and breast cancer syndromes and the Lynch syndromes. So therefore, at the outset, we have our first target is to identify whether we are dealing with any of these high-risk groups. We all know that ovarian cancer is a silent killer, and usually the symptoms and signs are non-specific. So in 2009, Goff et al., they classified these symptoms and they characterized them into main 3 groups. So 8 symptoms, which were clustered into 3 main groups, which included pelvic abdominal pain, increased abdominal size or bloating, difficulty in eating, feeling full, increase in urinary frequency or urgency. And they said that the symptom index will be positive if any of the 8 symptoms are present more than 12 times per month for less than 1 year. And this carried a high sensitivity of around 65% and around 85% specificity to diagnose ovarian cancer in these women. So these are all non-specific symptoms. But whenever you are taking history, especially in a postmenopausal woman, please do pay attention if the woman complains of increased abdominal size, bloating, and all these symptoms. We also did a similar study in a hospital in which we evaluated the symptom index, and we found that this index had a 78% sensitivity and a 90% specificity for predicting ovarian cancer. Abdominal pain was most prevalent symptom, and most of the symptoms appeared within 3 months of diagnosis of cancer. Even in non-epithelial ovarian tumors, they are more likely to present with a palpable abdominopelvic mass and acute abdominal pain. Lots of girls, they present with torsion. Many women with although we say that malignant masses do not tort. But yes, we should keep in mind the borderline tumors which may also undergo torsion. So do not ignore whenever we are evaluating a woman with abdominal pain that she may also harbor some kind of borderline or a malignant tumor. Then abdominal distension, presence of ascites, again a very hallmark feature of malignancy. Then even fever is a presentation, especially in some germ cell tumors we can find. And also menstrual irregularities, vaginal bleeding, hirsutism, virilization, these kind of endocrinological symptoms can be seen in women with the hormone-producing tumors. On examination, when should we have the red flag signs? What are the signs? Presence of an irregular nodular mass, solid mass, fixed bilateral masses with ascites. These are the features of malignant masses. But however, they have a limited role if the patient is obese. Sometimes you have young people examining, just out of post-graduation, so they may not be very experienced. And also certain benign conditions like endometriosis, presence of tubercular masses, inflammatory masses, and fibroids may mimic this kind of malignant features. Again, we did an analysis of adolescent masses in a hospital, and we found that malignancy was more common in early adolescence, while non-neoplastic masses were seen more frequently in the late adolescence. So once we evaluate the patient clinically, now the next step comes is imaging. And as you can see, a good ultrasound, a good transvaginal sonography, and a transabdominal sonography has a very high sensitivity, around up to 90%, to adequately characterize an adnexal mass. And in our hospital, we do our ultrasounds on our own. We do not rely much on the radiologists. And what we see and what we analyze on the mass that is what our impression is. And if you add Doppler to it, the specificity further increases from 80% to 90%. MRI also carries an equal sensitivity to in ultrasound imaging. However, it is only useful when the masses are indeterminate, and this I will be coming to it later. So on ultrasound, there are certain morphological characteristics and risk prediction models which have been developed these days, which help us to guide that what kind of mass are we dealing with, whether it is benign, whether it is borderline, or whether it is a malignant mass, and what is the risk of malignancy in that particular mass. So the most famous is the IOTA classification, that is International Ovarian Tumor Analysis. They have laid down very simple rules, the B and the M rules. Then they have developed some models, which are the logistic regression models. Then certain indices have been made by the American College of Radiology, which include the morphological indices. Then they have the GYRADS, that is the Gynecologic Imaging Reporting and Data System. It is a kind of a BIRADS sister concern, which BIRADS is for breast, GYRADS is for gynecological masses, adnexal masses. And then we have the ORADS, which is an ovarian adnexal reporting and data system. I'll be coming to them one by one. So as I said, IOTA has laid down these very simple rules, and they have been classified as the B rules or the benign rules, and M rules or the malignant rules. So what is a B rule? What is a benign cyst? A unilocular cyst, or presence of a solid component where the largest solid component is just less than 7 millimeters, presence of acoustic shadowing. Then a smooth multilocular tumor which is less than 10 centimeter, and when there is no abnormal blood flow in the mass. That is the B rules. What are the M rules? If it's an irregular solid tumor, if there's ascites, at least 4 papillary structures, if there's irregular multilocular solid tumor with the largest diameter more than 10 centimeters, and if the blood flow is very strong. These are the M rules. So how do we apply these rules? If there is one or more M rules applied in the absence of a B rule, the mass is classified as malignant. If one or more B rules apply in the absence of an M rule, the mass is classified as benign. And if both M and B rules apply, or if no rule applies and the mass cannot be classified, it is inconclusive, and it is in this category where we will need a higher imaging like MRI. So IOTA simple ultrasound rules, they have a good sensitivity of around 90% and the specificity is around 93%. And this is the logistic regression model, which is again developed by IOTA, in which apart from the various ultrasonological features, they have included age of the patient, the history of hormone therapy, and presence of pain, also in the analysis, and then they give an estimate that whether this mass is malignant or not, and accordingly, the treating physician can manage. Then coming to the GYRADS, as I said, this is like a BIRADS model, reading with the gynecological masses. There are 5 categories, which range from definitely benign to probably benign, then malignant. And again, the features which deal with malignancy are thick papillary projections, thick septations, presence of solid areas, ascites, which are again the signs which are suggestive of malignancy. Each category gives an estimate probability of how much is the probability of malignancy, and this entire reporting system carries a good sensitivity, specificity, positive and negative predictive value. This is a very heavy slide, a very complex slide, so I'll just explain it in detail. This is the ORADS system, which is the most in vogue these days. So ORADS 1 is basically a normal ovary where you have follicle, corpus luteum. So this is definitely, there is 0% likelihood of malignancy. Then ORADS 2, in which you have a simple cyst. Then you have classic benign lesions, which include a hemorrhagic cyst, dermoid cyst, which is less than 10 centimeter, and endometriomas, a peritoneal inclusion cyst. And again, the likelihood of malignancy is less than 1% in ORADS 2. In ORADS 3, the risk is slightly increased, in which the size of the tumor of the cyst is more than 10 centimeters. Its multilocularity is present in some solid area also appears. Then you have ORADS 4, which is an intermediate risk category, and then you have ORADS 5, which is a high risk category. Now, the advantage of this system is that not only it describes the lesion, but it also gives you some kind of management guide about the premenopausal and the postmenopausal cysts, what to do. So, for instance, if you have an ORAD score of 1, which is a normal ovary, nothing is to be done. If it's an ORAD score is 2, in which the adnexal mass is almost certainly benign, we have simple cysts, you can follow up, you have classic benign lesions, you can manage accordingly. You have a dermoid, go for laparoscopy, you have an endometrioma, treated accordingly. So accordingly, you have to see there how to manage these classic benign lesions. And then also, if you have a non-simple unilocular cyst, smooth inner margins, again, you can follow up in a premenopausal lady, but in a postmenopausal lady, you have to go for a specialist MRI, a specialist ultrasound, and you have to be more concerned if suppose any features are suggestive of other features. Then you have ORADS 3, in which there's a lower risk of malignancy. Again, try to get a specialized ultrasound or an MRI, and then you can accordingly the management can be done by a gynecologist. But ORADS 4 and 5, Here you need an advice of a gynec oncologist. At the consultation, go to gynec oncology MDTs, and then the treatment plan has to be sorted out. ORAD 5, definitely, she is a high risk of malignancy and she should only be dealt by a gynec oncologist. Now, what about the other imaging modalities? What about CT, MRI, PET scan? Everything is available. Now, the patients come to us first with CT without any ultrasound. So what is their role in evaluating an adnexal mass? CT scan is basically for malignant ovarian masses, to see the disease spread, to see whether we can operate these patients or we need to go for neoadjuvant therapy. So CT scan should be done only for malignant masses. Then how, as I said earlier, what about those indeterminate masses where we cannot make any decision? MRI. MRI is the one in which if you have any doubt about morphology, when the cysts are indeterminate, when you are not able to characterize whether it's an adnexal mass or whether it's a non-adnexal pathology as a pelvic mass, MRI is the investigation to be done, which is second line after ultrasound. It is the one which helps in differentiating the origin and further characterizes the masses better. And also MRI can be done further when you're dealing the brain metastasis and whenever you have lung mets in ovarian cancer. What about PET CT? It should not be done. It is very confusing. Active ovaries uptake PET. They have an FDG uptake. They show positive, and then the patient will come with that I have got malignancy, and it will just be normal ovaries taking up the FDG. So it is not useful in the preoperative assessment of adnexal masses. But yes, if you're dealing with a malignant mass and you want to rule out any distant metastasis, you can go for PET CT, and it is more useful when you're following up the patient post-surgery for malignancy. So after TS and TVS, the second investigation, which is important to characterize the adnexal masses, is an MRI. All right. So now we come to the second aspect of it. What is the role of tumor markers? We have a wide range of tumor markers available, and now I'll be trying to make you understand what is the tumor marker to be done and when and why. So first and foremost, CA125. It is a Google marker, I call, because nowadays even the laymen, they know what is CA125, and whatever they will do, they will always come with a CA125 report, even if it is not been advised by any treating physician or a gynecologist. So normal serum levels of CA125 was up to 35, and it's a very good marker for epithelial ovarian tumors, but again, in early stage disease, it is only elevated in 50%. It is when there's peritoneal involvement, when there's ascites. In late stage ovarian cancer, it is more likely to be elevated. Mostly it is seen with serous cancers and endometrioid tumors, and least commonly seen with the mucinous epithelial ovarian cancers. However, one of the major disadvantages of CA125 is it can also be elevated in benign conditions like endometriosis, even in pregnancy, menstruation, and therefore we have to take it. It's very important to note that when this tumor marker was being done, especially in the premenopausal age group. So how to increase the sensitivity of CA125? The answer came with HE4. So HE4 is another tumor marker which is elevated in the serous and endometrioid epithelial ovarian cancer. If we compare this with CA125 at a 95% specificity, it shows a higher sensitivity. It is better than CA125 that to distinguish between benign and malignant ovarian masses. So whenever there's a confusion and facility is available, go for HE4, as it is also not influenced by physiological conditions like and also endometriosis. So with this, we have an algorithm called as risk of ovarian malignancy algorithm, that is ROMA. And ROMA is very good. It is FDA approved. In premenopausal women, the cutoff is taken as 13%. That is 1.31 if we take it like likelihood ratio. And in postmenopausal women, it is 2.77 is the cutoff as likelihood of malignancy. And it is this ROMA actually combines both HE4 and CA125 in an equation and gives us the prediction of malignancy. So ROMA is useful whenever you have a doubt, when you have CA125 elevated and your morphology on ultrasound is, kind of more likely to be benign or borderline. So ROMA proves helpful in that aspect. Now, what about the other tumor markers? If you're dealing with bilateral ovarian masses and your ovarian morphology is maintained, and in that case, you have to be very suspicious that it may be a metastatic tumor from GIT, from breast. So in those cases, CEA is a very important tumor marker. In that case, elevated CA, you have to perform an endoscopy to rule out a GI primary. And also, it can also be elevated in primary ovarian malignancy, especially mucinous, Brenner's, endometrioid tumors. And a ratio is very important. If a CA125 CEA ratio is more than 25, it is more suggestive of a primary ovarian tumor. What about CA 15.3 if we have a breast and ovarian epithelial malignancy? So whenever you have an elevated CA 15.3, it warrants a mammography in an ovarian mass which is seemingly malignant. CA 99 may be elevated in mucinous carcinomas, and therefore when you're suspecting the bilateral ovarian masses, always get a CA 99. It may also be elevated in pancreatic tumors. Now, what about these germ cell tumor markers? This we've been, from ages, it has been like these 4 tumor markers are the hallmark for germ cells. That is beta-HCG, alpha-fetoprotein, LDH, and CA125. And in routine, we should measure these 4 markers, especially in any woman who presents with a suspected ovarian malignant mass who is less than 40 years of age. You can have any of these germ cell tumors, and these markers are very specific, like AFP is for endodermal sinus tumor, and dysgerminoma, we have beta-HCG and LDH, and so on and so forth. Now, certain tumors, we know they are sex-caused stromal tumors which may secrete certain hormones. The granulosa cell tumors, when you're suspecting like Adnexal mass with abnormal uterine bleeding, in that case, we can always get an inhibin levels done, which will point out towards granulosa cell tumors. Then Sertoli-Leydig cell tumors, the testosterone is a tumor marker. And for carcinoid tumors, which are very, very rare, 5-hydroxyindole acetic acid is the tumor marker for carcinoid tumors. So, how do we integrate these two now? How do we combine imaging and tumor markers? So for this, again, we have the various algorithms, and out of which 2 very important and commonly used algorithms are the RMI, that is risk of malignancy index, and then we have another one which is given by IOTA, that is the IOTA Adnex model. So risk of malignancy index is most commonly used in UK. It is it was developed by the RCOG guidelines. It is there, and they manage their masses according to the RMI. So RMI is what? It's a score in which you multiply the ultrasound score, the menopausal status, and the CA125 levels. So the ultrasound score is scored 1 point each for the following characteristics, like a presence of a multilocular cyst, solid areas, metastasis, ascites, and bilateral lesions. So you give a score accordingly, like use 0, 1, or 3, and then you have menopausal status. 1 is for premenopausal, 3 is for postmenopausal, and then serum CA125 is measured in international units per milliliters. So you multiply these 3 factors, and RMI score of 200 is the cutoff. So more than 200, highly suggestive of malignancy. Less than 200, the chances of malignancy are less. So the sensitivity of this score is around 80%, and the specificity is also around 87 to 90% in various studies. And it has been very reproducible, and it is very commonly used. And it is the score which is used to triage the Adnexal masses in the UK routinely. Then IOTA also developed an Adnex model. Now, this Adnex model is a very, very useful tool. It is available on the App Store, both on Android as well as on the iPhone also. So this Adnex estimates the probability that this Adnexal tumor is benign. Is it borderline? Is it a stage 1 cancer, or you're dealing with an advanced cancer, or you're dealing with a secondary metastatic cancer? And as you can see here on the right-hand side, lower down, this is how your app will appear. So this is the various parameters which are there in the Adnex model. So which includes the age of the patient, whether your center is an oncology center for gynec oncology or not, then the maximal diameter of the lesion, the maximal diameter of the largest solid part, presence of loculation if there are more than 10, number of papillations, whether there is acoustic shadowing, yes or no, presence of ascites, and serum CA125 levels. And then you just press calculate. Then what will it show like? It will appear like this. A graph will appear which will show what is the probability whether your tumor is benign or whether it is malignant. And if it is malignant, what is the probability of whether it is a borderline tumor, a stage 1, a stage 2 to 4, or a metastatic. So it's a very good model, and on validation data, at a 10% risk cutoff of the total risk of malignancy, the sensitivity is almost 96% and the specificity is around 70%. In my department, I'm carrying out a thesis. My postgraduate is doing a thesis comparing the Adnex model and GYRATS, and we recently evaluated the results. The Adnex model has a very good reproducibility. The sensitivity in our study is almost 92%. Specificity is 95%, which was higher than what has been documented. And GYRATS also although showed a very good sensitivity, but specificity was not very high. So Adnex model, we are really following this model. So once you've decided that whether what is your characterized mass, whether it is benign, borderline, malignant, what is the probability, what is the risk estimation, by using any of the scoring system, by using any of the criteria. Now, next step is management. I'm not going to go into detail about management, but I'm just going to address a few concerns which we as gynecologists face every day when we see adnexal masses. So whether we can conservatively wait and do a wait and see approach, or we can have to do an immediate surgical intervention, whether we should go in for laparoscopy or whether we go for laparotomy, whether this mass is to be dealt by a gynecologist or a gynec oncologist, and whether we need to do a conservative surgery or a complete staging procedure. So just a few tips and tricks from the guidelines and what we experience in day-to-day practice. So when is observation recommended for a patient with an adnexal mass? It's very important to identify what mass are you dealing with morphology. As I said earlier, please look for how the mass has been characterized on morphology, and if possible, try to do ultrasounds on your own. So a premenopausal unilocular thin single septa mass, which is around 5 to 7 centimeter, you can watch. A postmenopausal mass up to 1 centimeter, but yes, 1 centimeter is a very small mass. So usually you do a scoring where is RMI. So RMI less than 200, a 5 centimeter unilocular simple cyst, unilateral, we can do weight. And how do you wait? How do you watch? You repeat an ultrasound, do a CA-125 in 6 months. If the cyst is unchanged, you can switch over to annual screening. And 2 to 3 years, everything is stable. You can discharge as and when appropriate after discussing with the patients, after weighing and explaining to her everything, what is the possibility. But when the patient is on conservative management, when should you stop? If suppose on ultrasounds, which are doing serially, there's an increase in size, some suspicious morphological changes appear. There are complications like torsion or hemorrhage, or the patient becomes symptomatic, or there's persistent cyst at extremes of age, which is the high risk group. In that case, do stop your conservative treatment and intervene with surgery. Now, what about aspiration of cysts? Aspiration is not recommended for management of ovarian cysts. Only
Hold on, Dr. Bindiya, just a minute. Someone else has creeped in. Hold on. Yeah. You present your screen again. Make it full screen.
I was presenting, yeah?
Yeah. Now you make it full screen, yeah. In between, someone else crept in, yeah.
Okay, just
share your screen again.
All right, yeah, I'll do that. I think I was sharing, ma'am. It is not showing.
Actually, someone came in between and started sharing, so it's gone off now. I think now you re-share. I think now you
I'll share it.
Yeah.
So I should start from the management part only, or
aspiration part is what we're talking about.
All right. So okay. So we've stopped. Okay. I did not know where things went wrong.
No. I stopped you immediately. Yeah. Role of aspiration.
Okay.
That's fine.
So is my screen visible now, ma'am?
Yeah.
All right. So now what is the role of aspiration of ovarian cysts? So aspiration routinely is not recommended for management of ovarian cysts. Only if we need to palliate the symptoms, or we need to do some symptom control in women with advanced malignancy who are unfit to go surgery or for further intervention. In those cases only it is recommended. Otherwise, it may lead to inadvertent upstaging of a malignant tumor. There are also high rate of recurrence when you aspirate a cyst, and also tumor cells may get implanted along the needle track. Also, sometimes, we aspirate that, okay, we can send it for diagnostic cytology, but it is found that the sensitivity is very poor, just around 50%, and therefore, role of aspiration for ovarian cysts is not there. What about occipals? A lot of patients give, functional cysts. Let's give a 3-month challenge of occipals. And studies have shown that they do not promote the resolution of functional ovarian cysts. So it's better to monitor and keep them under surveillance rather than putting them on occipals. Then another important question which comes to our mind is what type of surgical intervention is appropriate for a presumed benign adnexal mass? Like I discussed earlier, those masses which are, presumably benign, like endometriomas, dermoids, always go for laparoscopy. And this also depends on a surgical experience, the skill. So surgeon parameters are very important to decide that how to deal with a presumed benign adnexal mass. A preoperative counseling is also very important. Always tell them that there is a risk of conversion to laparotomy. And during laparoscopy, care not to rupture the mass. Always try to have the visual entry by VisiPort. Try to avoid venous needle if possible, because they say sometimes it may lead to inadvertent puncturing of the ovarian mass, especially if they're big masses. And try to remove the masses intact without intraperitoneal spillage. Use retrieval bags. And if suppose inadvertent spillage occurs, do a meticulous peritoneal lavage and using large amounts of warm fluid. And whenever you're dealing with women in reproductive age group or adolescents, always prioritize ovarian conservation to preserve fertility. Then, what do we do? Suppose we are in with the laparoscope and now we have some suspicious masses coming. So whenever in doubt, send frozen section if facilities are available. It's almost 70 to 80% concordance is there. However, if they're larger tumors or there's mucinous histology, then the concordance may go down. But yes, if suppose facility is available, try to send a frozen section. And do not hesitate in converting to laparotomy. If suppose you're opening a lady and you find there's features of borderline tumors, on laparoscopy, the cyst has ruptured, some suspicious solid areas propped in. So always do not never hesitate to convert to laparotomy, do a staging procedure and with a midline incision, send cytology. So therefore it's a surgeon's discretion. It's your very important is surgeon's skill and the knowledge, and therefore always counsel the women beforehand that these are the probabilities which may happen when we are dealing. But yes, it is not required in always all the masses like endometriomas and dermoids we can really manage well. But sometimes when you're managing some borderline tumors, they can be present anytime. Now, when should we refer to gynec oncologists? So women with elevated CA125, some ultrasound findings suggestive of malignancy, ascites, nodular fixed pelvic masses, evidence of some abdominal distant metastasis, always rope in a gynec oncologist with you. And premenopausal, postmenopausal women in which we have done the scoring systems, we have a high RMI, more than 200, a high Roma, ORAD's score of more than 4 to 5, and even our Adnex model and IOTA LR shows a high likelihood ratio of malignancy or borderline tumors. We should definitely go for an gynecologic MDT and always go for consultation with the gynecologic oncologists. So with this, this is a very theoretical, the entire theoretical lecture has been covered. So now with this knowledge, I would like to discuss a few case studies to just show how to work up and diagnose some cases which are presented to us. So these are all the cases which we did in our thesis. And so I'll just present 4-5 cases here so that we can have a better clear understanding of how to deal with the adnexal masses. So this is a 45 years old lady with para4 Lie3. She presented with a right adnexal mass with abnormal uterine bleeding, multiple comorbidities, hypothyroid, fever, splenomegaly, thrombocytopenia, anemia. So initially we thought that AUB is because of all these fevers, splenomegaly, thrombocytopenia. And when we did an ultrasound, I'll just show you the picture subsequently, we said, no, this looks like a solid mass. So let's get the tumor markers. So tumor markers were done almost normal. CA125 was just 75. But then she had AUB. So I said, no, let's get the inhibin levels done. And inhibin levels came out to be 877, which is very high. Endometrial biopsy was done because high inhibin levels always go for associated hyperplasia or malignancy should be ruled out. So we did an endometrial biopsy. It was hyperplasia without atypia, and this was what the ultrasound picture looked like. So if you can see, this was a ovarian mass with solid area with some kind of hemorrhage, and multiple thick septations were there, and again multiloculated mass. And as I said, we do the Adnex scoring, and the risk of malignancy was almost 50% in this patient. And this was the intra picture. This is the ovarian mass which came out, and as you can see how beautifully the cut section is collaborating with the ultrasound picture. There were areas of hemorrhage, there were areas of solid areas. So it was almost like a replica of your ultrasound imaging. So we have an idea of what we are dealing with when we're doing an ultrasounds on our own. So this came out to be a granulosa cell tumor, which was stage 1. So complete surgery was done in this patient. Now, again, an importance of ultrasound in this case, she was para 2, live 2, postmenopausal women, typical, malignancy, distension, vomiting, loss of appetite, CA125 was 4,000, and we knew that we are dealing with a malignant mass. So even the mass in the CT scan showed it was very close to the rectum, and this was the picture on ultrasound. Now, how malignant can this be a mass? A small mass in the ovary, and with some areas here and there, and this is what the ultrasound showed. But when we went to a higher magnification, what I found very suspicious was this area. Now here, if you can see, some kind of floating material was found very close to the with the ovarian mass. So here we found that this is the rectum probably, and this mass is very closely adherent to the rectum, and we might need to do some extra procedures in this patient. So again, Adnex scoring here, obviously the 100% chance of malignancy was there even without the Adnex. So what I want to show you, if you see the cut section, we had to go in for an exentration in this patient. So if you see the mirror image of an ultrasound here, again, this is the whole solid mass with these cystic areas. And as you can see here, the floating picture which we found here was the colon, was a sigmoid, rectosigmoid portion. And this we removed along with the tumor intact. And this we did a modified posterior exentration in this patient. And this patient is doing very well. And this almost a 1-year follow-up is there in this patient. So we are able to decide the surgeries on the basis of ultrasound, and they help us to guide what kind of surgery we have to do and how to deal with it. So this patient has an end coloscopy and she's managing it very well. So this was a high-grade serous ovarian cancer. Now coming to the third case, this is a 40 years old para 3 live 2 with a 14 centimeter left adnexal mass. Now again, 40 years old, we did the panel of tumor markers, and here CA125 was 910, CEA was 29, and CA99 was 12,000. So definitely a malignant mass. But yes, here the ratio came into this thing. CA125 CA ratio more than 25, most likely it's a primary ovarian pathology. But because the CAEA levels were high, as I told earlier also, we went in for an upper GI and lower GI endoscopy, which was normal. And here this was the mass. So multiple loculations, multiple cystic areas, and some solid area also where there was color flow on Doppler. And again, the risk of malignancy was high in this patient. This was a tumor which was taken out, and this turned out to be a mucinous cancer, moderately differentiated stage 2. And again, you see the multiple loculations. Here also the tumor multiple loculations with solid areas. So an ultrasound is actually a reflection of what you're going to get here in your intraop. Then coming to the fourth case, this is a 41-year-old lady. She presented to us with an 18-week size lump abdomen, and there was a mass in the anterior fornix. And there were no coma. There was just, this was the only presenting complaint. She was previous LSCS, and she had a scar endometriosis also. Tumor markers we do in all the patients. So this was a tumor marker profile, which is almost normal. This was the picture. Again, as this shows a very clear dermoid, because as you can see here, the floating sebaceous material and this typical posterior acoustic shadowing which was seen in the dermoid. Adnex score we always calculate because it was a part of a thesis, and chance of benign tumor is 94% in this case on the model. And this was a dermoid which we did, and as you can see here, typical hair. So probably this was a tuft of hair which you can see, and this was a sebaceous material which was floating in the cyst, which was a mature cystic teratoma. Now coming to the last case, this was a 29-year female. She came to us with a huge distension mass almost reaching up to the epigastrium. CA125 was 26, and it was a large mass as in the CT scan also suggestive of a mucinous tumor. Now this patient is very interesting. She was destitute, but she could not afford anything. But she had a CT scan with us. God knows where she got it from. She had no ultrasound with us. So that is why people just come to us with anything. So this was a typical ultrasound pitch. This we found floating mucin and multiple loculations in this on the ultrasound imaging. Adnex model here is very, it came out to be a very reliable predictor because chance of benign tumor was 80% in this case. Risk of malignancy was only 20%. So we did, this was a huge tumor, and as you can see here, all the cut section again shows multiple loculations, mucinous areas, and this was a benign mucinous cystadenoma. So these are the few algorithms which are there for management of premenopausal ovarian cysts. So as I said, in the premenopausal ovarian cyst, if it's a single cyst, Simple cyst, more than 5 centimeter, around 5 to 7 centimeter, your RMI, do an RMI. If it is less than 200, you can just go for laparoscopic surgery. If it is, RMI is more, in that case, you have to go for a gynecological MDT review. And less than 5 centimeter functional cyst, you can even just go for observation, like we mentioned earlier. And sequentially, if everything is normal, you can even discharge the patient. And this algorithm is for postmenopausal ovarian cysts. Here we are more cautious. We take a cutoff of 1 centimeter, RMI less than 200, lower risk of malignancy. And if suppose all the criteria are benign, you can consider conservative management and follow-up. And if so, any features which are suggestive of more than 5 centimeter multilocularity bilateral cysts, in that case, go for bilateral salping oophorectomy. Anything which is more than 200, always involve a gynec oncologist. So to conclude, it is basically a combination of clinical suspicion, imaging, and tumor markers when we're dealing with adnexal masses. We need to identify the high-risk groups, and imaging, a combination of transabdominal sonography and TVS is the first-line investigation. IOTA, B, and M rules, which are simple rules, are very easy to interpret and follow. Tumor markers are a useful adjunct in diagnosis. We have excellent prediction models these days, available as apps and available as scoring systems, which are Adnex, RMI, Roma, ORADS, and GUIDADS, and we highly rely on the Adnex model. Then for management purposes, if you have a single unilocular cyst, benign, less than 5 centimeters, you can manage them conservatively, especially in the premenopausal women. And for apparent benign masses, laparoscopy is the treatment of choice. Avoid spillage. Any suspicion, go for frozen section, go for staging laparotomy with a midline incision, and whenever RMI is more than 200, ORADS is 4 or 5, at next model presents malignancy, always refer to a gynec oncologist. Thank you very much.
Wonderful. Very good presentation, Dr. Bindiya.
Thank you, ma'am.
Excellent presentation, Vidya.
Thank you very much, ma'am, for giving this opportunity. I hope I have made them clear.
It was
Very, very clear.
wonderful.
Thank you, ma'am.
Wonderful.
Dr. Ila and Dr. Raj, would you please?
Yeah, I would like to say, Dr. Bindiya, it was a wonderful presentation. And because when we start incorporating so many things in our clinical practice, then sometimes it becomes very confusing. So I request you to give us a very practical 3-point thing that's okay, that we do management like this, but what tumor marker actually we should do it practically, because there are so many tumor markers and they are very expensive. So though in the premenopausal we usually look for the germ cell tumors and we go for those tests, but in postmenopausal, should we go for other, like CA125 is one, and other whatever tumor markers, 19.9 or something, should we go for them, or HE4?
Yeah, so ma'am, with this, as you rightly said, in premenopausal,
What do you say that typically should we go for all the tumor markers?
Yeah. So as you said, ma'am, so first of all, most important is imaging. So you have to really see what your imaging says. So if your imaging says is suggestive of benign disease, then I said even tumor markers also is not required. It is very important to first see the imaging part. And as far as tumor markers are concerned, in premenopausal age group, less than 40 years, whenever we deal with ovarian masses, we should get a germ cell tumor panel, that is for sure, along with CA125. And for postmenopausal women, CA125 is a very reliable tumor marker. You can definitely go ahead only with CA125. But yes, if you have bilateral masses, if you have a mucinous histology, a mucinous morphology on ultrasound, then definitely do a CEA and CA19-9. You know, they are very important because they might be a metastatic tumor from colon, from GIT, right, from breast. So therefore, it is very important in bilateral masses, and whenever you're suspicious, whenever you have multiloculated mucinous kind of masses, then you should definitely go in for CEA and CA19-9. And as far as like if you have a breast mass in this suspicious mammography, in that case you go for CA15.3. Otherwise, CA125 in postmenopausal women is a very good guide. And as I said, what we are doing nowadays is Adnex model we've seen from our study also. It's very good predictor of whether we are dealing with a malignant mass, whether it's benign, whether it's borderline. And in that tumor marker, in that this thing also, CA125 is the only tumor marker which they consider. They're not considering the other tumor markers. And other tumor markers like inhibin, like I said, I showed the case in which the women came with AUB, which we first attributed to fever, splenomegaly, thrombocytopenia. But then we thought that no, it's an Adnexal mass with AUB, we should go for inhibin. So that is, then we can go symptomatic wise.
Okay, so in all the malignant patient who come with the masses, and when you open, you find that it is probably a malignant one. Do you send it for frozen section in all of the cases, or you just?
Yes, ma'am. If it's like very obvious malignancy, then in that case, frozen section sometimes is not required, especially if you have an elevated CA125 and you're prepared that you might come across a malignant mass. But we do a frozen section for all the adolescent masses, especially when we're dealing with like the adolescent ovarian masses. And we also do whenever there's suspicion. So frozen section we routinely do in suspicious ovarian masses. Like we recently had a young girl, 13 years old girl was there with solid ovarian mass. She had AUB. And even in that girl, we got inhibin levels done, ma'am. And the inhibin levels came out to be 1600 in a 13-year-old. So we were dealing with a premenarchal granulosa cell tumor. A 13-year-old, we cannot just do surgery like that. We have to do, we have to be very, very careful. So we did do a frozen section on that case. It came out to be a granulosa cell tumor frozen section. We had counseled her. We just proceeded only with the right salpingo-oophorectomy and a complete staging with omentectomy, with some omentectomy and biopsies, and patient is taking chemotherapy. So this kind of frozen section is very useful in these kind of girls especially. So we routinely do frozen section in suspicious masses and where we do not have a clear-cut diagnosis and there's a dilemma.
Very nice. Thank you so much. And I would like to comment that all of us should, first of all, learn the ultrasonography to see the ovarian masses ourselves. That is first and foremost thing. And secondly, when we go for these kind of many of the benign tumors, unnecessarily people are going for CA125, a smaller cyst, 4-5 centimeter cyst, unnecessarily they are being tested like for the malignancy and all that. So those things we should take home messages that one should not extraordinarily do the investigations in such cases, because clinically and ultrasonographically you are able to diagnose to quite an extent.
Can I ask one question?
Yes, ma'am, sure.
First, one question is that if we are operating a benign tumor, okay, clinically and ultrasonologically, it is a benign tumor, but it is very big. When we are opening the abdomen, we don't do laparoscopy. So to deliver the big tumor from the abdomen, it is very difficult. So sometimes we do some puncture and take out it from a smaller incision. So what do you say about that? Is it okay, or we should give the big incision up to the ziphus sternum to deliver the ovarian tumor, and clinically and peroperatively we seems that it is a benign tumor?
Ma'am, so if it is you're very sure that the tumor is benign, your tumor markers are all negative and your ultrasound suggests of a benign tumor, we do, there's no need to open up to the ziphus sternum. We also aspirate the tumors intraoperatively.
Yes.
And
that is what I want to ask you, whether we are doing the right thing or not.
But one more important thing is that in that case, you have to be very, very cautious. Whenever you give a purse string incision, put packs around. Avoid the spillage into the abdomen. So you have to just stabilize the tumor.
Those kind of, yes.
Put a purse string. And also, there was a very good thing which we did. Some people also use an endo bag kind of a thing. They open it and they go through the plastic bag so that when the tumor is decompressed, it comes inside the endo bag. So that is also one of the this things, so that doesn't spill out. So also in that, whenever you're doing an aspiration, you have to avoid spillage at all costs. That is important.
And one more question that you have not discussed about MRI. What is the role of MRI? Is it important?
Ma'am, I said about MRI. And in MRI, if suppose the masses are your indeterminate morphology or inconclusive masses, you're doubtful about the origin of masses on ultrasound, then you can go for an MRI.
Okay.
This is the second line.
I joined 10 minutes later. Okay, thank you so much.
Dr. Raj from you.
Excellent elucidation, Dr. Bindiya.
Yes, excellent.
And so many take-home practical tips for the general gynecologist, not as a specialist gynecologist. What are the including the clinical feature, right from the clinical feature, then the ultrasound finding, which they should see themselves. Also, along with, you have to correlate with the tumor marker specific to the type of the tumor you are dealing with. And then this, I didn't know, though we are doing practically Roma index and HER4 to do the calculation of the risk malignancy. But this Adnex calculation, I was not aware, which I learned from you. And maybe we will adopt it in our clinical practice. And one thing is there, in the adolescent, you have to be very conservative. I have an experience of one girl who was just 17 years, and on the CT scan, the first episode of continuous menorrhagia, and on the ultrasound, there was a unilateral cyst, and we thought it may be endometriotic. We got the CT scan and the CA125, because before this I was never getting all the tumor marker even in the adolescent. And then we took her for the laparoscopy surgery. But on the laparoscopy, when we were doing and dealing with the cyst, it was very unusual presentation, very vascular. And because the consent was not there, we have to do a cystectomy only. But to my surprise, even after calling the pathologist in the OT, they could also suspect it may be a germ cell tumor. And the histopathology finding was germ cell tumor. Then we have to do a second staging. So the counseling when you are dealing, especially in the adolescent, the counseling part is very important.
Yes.
And you can do a second stage surgery, complete surgery. And I have followed that girl. We did a unilateral salpingophractomy with omentectomy and all the complete multiple biopsy and all these. She got married, she has 2 children, and now still she is following. Yes, so that's what I want to convey. In adolescent, dealing with the adolescent, we have, and even in the premenopausal, the counseling and the consent part is equally important.
Definitely. It's very important, and with every laparoscopy, when you can have all surprises, point of surprises. Yes. So beforehand, tell the patient that, you might need a laparotomy. There is a risk of laparotomy. You can have some suspicious things, and we can have to do some more procedures. So especially when we're dealing with kind of, the mixed type of not very benign masses laparoscopically. So in that case, it's very important. And definitely counseling plays a very important role, ma'am.
Madam, from you, your expert opinions, ma'am, from you.
I think it was a super presentation. I find, my clinical practice also shows that, if you've done an ultrasound in our setup, we find we have an advantage. And it's exactly the mirror picture comes when you operate such patients. So this is exactly what I feel. The trend which has gone in the gynecologists that जरा सा मास देखा गया MRI करेंगे CT करेंगे without the confusion where you पता नहीं CT में क्या मिलने वाला क्या MRI में मिलने वाला. So this is what it is the MRI is. I have never seen it is giving you any advantage. Your ultrasound should be absolutely good about it. I am also not very fond of markers except in a perimenopausal patients. I definitely get CA125 when I get a complex mass, and I get a CA19.9 also done. And sometime CA because we avoid because it's more costly. And I think it was is absolutely great. The only thing which I wish to tell you is that the oncosurgeons are very few. And you should think about 90% of the India where the oncosurgeons are not available. You should definitely give the tips because, this kind of suggestions in your presentations that, oncosurgeon is required, tomorrow the judges and the lawyers start speaking about it. And when we know that we don't have very many people about it. So this is what, your guidelines should definitely be there, that what should gynecologists should do. I think the people who have taught you are the people who have not got MCH in oncology. But this is the roadmap must be taken. Otherwise, we are closing away the roadmap for almost 99% of the doctors. So I think your presentation should look for broader India, not India concentrated in metros. And this gives a bad idea to the judges when you make a diagnosis. I think on the whole, the presentation had been absolutely great too.
Thank you, ma'am. Thank you very much.
Thank you, Dr. Bindiya. It was an excellent presentation. Dr. Jyoti Bhaskar, ma'am, want to add something?
No, I don't know.
And another thing which I forgot about it, presence of ascites. Whenever you have mass, you find it in a complex mass and things like. If an ultrasonologist says there is no evidence of ascites, I have yet to find spread of malignancy. It doesn't happen.